Hello, I'm Henry Dunn. I'm an ENT surgical trainee in Cambridge University Hospital, and I do some research in the Department of Clinical Neurosciences at Cambridge University under Professor Bands. I'm really grateful for the chance today to talk to you about the work we've been doing looking into the anatomy of the semicircular canals, and specifically we'll talk about today how we can use this understanding to improve the treatment for patients with BPPV and the particle repositioning manoeuvre that's used to treat this. So first I'll take you through the contents of the talk. Hopefully we're going to cover a background to BPPV and the particle repositioning manoeuvre, the aims of the research studies we've been undertaking, some of the important findings including the anatomy of the semicircular canals and the variability of the anatomy, and the orientation of the canals during the particle repositioning manoeuvre. Then I'd like to take some time to talk about the work we've been doing to develop an earable, a wearable device that will hopefully be able to record head positions of patients during the manoeuvre and therefore improve the way it is performed in the clinic. And then we can look at some of the next steps for our research as well. So, BPPV is one of the most common causes of vertigo encountered clinically. It occurs secondary to displacement of otoconia from the otolith macular bed of the utricle and saccule into the semicircular canals, and most commonly into the posterior canal. And these otoconia are then called canaloliths. It's treated by the particle repositioning manoeuvre, which is shown in the diagram on the right here, and particle repositioning manoeuvres tend to be very successful. Epley first described the manoeuvre, and it's sometimes known as the Epley manoeuvre. However, there are many cases of treatment-resistant BPPV where multiple particle repositioning manoeuvres fail to improve the patient's symptoms. So as well as treatment-resistant BPPV, there are several challenges for patients to receive an adequate particle repositioning manoeuvre. Firstly, in a recent survey, primary care physicians reported that less than 50% of them were confident performing the manoeuvre, and therefore patients tend to wait for an ENT or vestibular therapist, and the waiting times are increasingly lengthy. In terms of the performance of the procedure itself, it remains to be very subjective, with the clinician judging the angle where they suppose the posterior semicircular canal to be in each position, and judging the angle they've oriented the patient's head to make sure they're doing the manoeuvre correctly. What's also quite interesting is in a paper in 1997, Epley himself commented that in the transition between position 2 and position 3, the apical segment of the semicircular canal doesn't align very well with gravity, and there is a risk of the canalith to be manoeuvred into the wrong direction, a phenomenon known as reverse migration. And this is highlighted here. You can see this segment of the posterior semicircular canal is barely pointing down towards the ground. In fact, Epley suggested that changing the second position to one with 60 degrees of neck extension would greatly reduce the risk of reverse migration. So our study aimed to analyse the anatomy of the posterior semicircular canals, identify if there is a degree of intersubject variability, test the alignment of canals during the particle repositioning manoeuvre, and then to develop our earable device to support the delivery of the manoeuvre. So firstly, in terms of looking into the anatomy and testing the general supposition that most patients' posterior semicircular canals will be the same, we used 68 CT scans of temporal bones and extracted anatomical features of the semicircular canals. Firstly, using PACS software, 2 radiologists measured the height and the diameter of each canal, and we found there was a degree of intersubject variability, with measurements ranging from around 6 to 9 millimeters. The mean height was 8.7 millimeters and diameter 7.3 millimeters, as shown on these 2 graphs here. We then looked into the anatomy in more detail using StradView software to segment the semicircular canals of the same 68 CT scans. We then used a principal component analysis to extract some key features, including the plane of best fit of each posterior semicircular canal. We then used all of these together to create a mean normal plane, and then compared each canal with the mean normal to calculate an angle of deviation from the mean. The violin plots here present that data, and interestingly, the majority of subjects, the angle of deviation from the mean was around 10 degrees. However, there are some extremes with up to 17 degrees of variation. It might be that this change in plane of the canal could be the cause of why some patients have treatment-resistant BPPV, and a specific manoeuvre might need to be developed to account for these variations. As well as the overall plane of the canal, other modes of variation were visualized in the dataset. The meshes presented here show the predicted mean canal in the black mesh and a computer-generated example highlighting some of the observed modes of variation, which include elongation, out-of-plane rotation, uniform scaling, and in-plane rotation. The figure here was our attempt at assessing Epley's statement that the second position of the Epley manoeuvre may not be optimal for aligning the apical segment with gravity. And we were able to show that our mean posterior semicircular canal orientation does not align well with gravity during the Epley manoeuvre in the second position, as highlighted in the middle bar here. Epley was right to suggest that 60 degrees of extension would achieve a much better alignment, and here we suggest a deeper head hang with between 60 and 65 degrees, achieving a 97 to 99% alignment with gravity of the apical segment of the semicircular canal. And this could have direct clinical implications for patients with BPPV. So how can we leverage these findings to help clinicians and increase access and therefore help our patients? We're developing an earable with inbuilt head and space IMU sensors, and this short clip highlights how our earable facilitates head tracking movements. We then tested these head tracking against the gold standard Vicon motion capture system, and we showed high degrees of agreement suggesting our head tracking algorithms are accurate. This slide here shows me wearing our earable device with some Vicon motion capture sensors during the Epley manoeuvre, and then observing the agreement of the Vicon and the IMU head tracking during the Epley manoeuvre in the figure on the right here. So how can we put head tracking earable with the anatomical study together to create an application to support patients? Well, we've given it a go, and this is what we've come up with so far. So here, when a patient wears the earable device during the Epley manoeuvre, we'll present an image of the semicircular canals to clinicians to ensure they're aligning each segment with gravity as required during each position of the manoeuvre. We're going to build on this work by further validating our earable device, improving the application, engaging with clinicians and patient and key stakeholders, and we've got ethics to now run a pilot study in BPPV patients in a clinical setting in Cambridge University hospitals. Other considerations to take this further into the future will be addition of eye tracking monitors, including EOG monitoring on the wearable device to look for signs of nystagmus, and developing specific manoeuvres with our anatomical models for other forms of BPPV, including lateral canalolithiasis. Thank you very much for listening.